So today I want to touch on female bladder outlet obstruction. So essentially for the talk today, I want to just get a brief overview of the etiology of different bladder outlet obstruction causes in women, and then specifically look at functional bladder outlet obstruction, urethrostricture disease, as well as post-anti-incontinence surgery as very different causes for bladder outlet obstruction. Specifically looking at evaluation, diagnosis, and management of these conditions. So essentially for normal voiding, we know that it is a coordinated process. It requires detrusor contraction, sphincteric relaxation, and also absence of obstruction. In terms of the actual definition of bladder outlet obstruction though, there is a very generic term for obstruction. So the ICS defines it as any reduced urine flow rate and or the presence of a raised PVR and increased detrusor pressure. The one thing is there is no real standardized urodynamic criteria for these females with outlet obstruction. And a lot of this is because there is quite a variable location of obstruction in females. So it can be the pelvic floor, the urinary sphincter, the bladder neck. And also they have a much shorter and more mobile urethra. And so that increases the complexity when we're trying to come up with a nomogram for these patients. So you can see here on this table, there's a lot of different criteria for definitions of bladder outlet obstruction. And that was kind of done since 1988 onwards. One of the most common definitions though is probably this one by DeFreitas. So a urinary flow rate of less than 12 milliliters per second, corresponding to a detrusor pressure greater than 25 centimeters water. That's been one of the more standard definitions, but as you can see, there are a very large number of different definitions for this condition. Some of the common symptoms you might see in bladder outlet obstructions are your classic weak stream of urination, maybe urinary frequency, hesitancy. These patients may have increased sense of incomplete bladder emptying as well as recurrent UTIs. They may also have more suprapubic discomfort and bloating sensations as well. So today I wanted to primarily look at, this is kind of the differential diagnosis, but includes functional, anatomic, and neurogenic causes. But I wanted to really focus on the conditions of primary bladder neck obstruction, dysfunctional voiding, and Fowler syndrome, as well as looking at female urethrostricture disease and anti-incontinence surgery. The other conditions, pelvic organ prolapse, urethral diverticuli or other obstruction, and neurogenic causes, these are quite large topics as well and can be their own separate grand rounds as well. So first of all, the incidence of bladder outlet obstruction is predicted to be about 2 to 8% out of all females. So it is important to maintain a high index of suspicion for any of these females presenting with voiding symptoms. And certainly in our evaluation, an accurate history, physical exam, followed by urinalysis and uroflowmetry, PVR. These are all useful tests in the evaluation of bladder outlet obstruction, followed by imaging in the form of either ultrasound, CT, MRI, voiding cystourethrogram, and also urodynamics. Certainly video urodynamics is a good tool for evaluation if we have access to it. So with primary bladder neck obstruction, the incidence is reported to be about 4 to 9% out of all females with bladder outlet obstruction, and essentially really is a failure of the bladder neck to open and funnel normally during voiding. So a lot of these patients will have your classic high pressure voiding with low flow, and on urodynamics, you may not see any increased external urinary sphincter tone. Video urodynamics, you would definitely see a classic failure of bladder neck relaxation for diagnosis. Treatment of this condition is variable. It ranges from conservative things, including clean intermittent catheterization to void and empty the bladder. An attempt at pharmacotherapy with alpha blockers can be instituted. And then, of course, bladder neck incision, classically 5 and 7 o'clock or 2 and 10 o'clock positions have been reported. Certainly, you do need to counsel these patients that there is a risk of vesicovaginal fistula formation, development of stress incontinence, or subsequent urethrostricture disease with these treatments. In terms of the next condition, dysfunctional voiding. So the ICS does define dysfunctional voiding as a intermittent and or fluctuating flow rate due to an involuntary intermittent contraction of the external urinary sphincter or the levator muscles during voiding. And really important is that these are in neurologically intact normal women. The main treatment for this condition is really biofeedback, because this is typically a learned condition. You can also try pharmacotherapy with baclofen as well as Flomax. And then for refractory cases, sacral neuromodulation and sphincteric Botox have been reported to be useful or helpful in this condition. So how do we really differentiate between primary bladder neck obstruction versus dysfunctional voiding? So Brucker's group looked at this back in 2012. They did a retrospective review of all female patients undergoing video urodynamics between 2003 and 2009. And they defined dysfunctional voiding as those patients where they saw either an increased EMG activity during voiding in the absence of abdominal straining, or if there was some radiographic evidence of sphincteric contraction. Of course, these patients did not have any neurologic condition underlying. They defined patients with primary bladder neck obstruction as those where they did not have any bladder neck opening during voiding. And they had about 16 patients with bladder neck obstruction and 34 patients with dysfunctional voiding. What they found was the overall maximum flow rate tended to be lower for patients with primary bladder neck obstruction at 7 milliliters per second versus 12. The PVR tended to be higher for primary bladder neck obstruction at 400 cc's versus 124. And one interesting parameter they found was that increased EMG activity alone, it was actually not a reliable predictor of differentiate between the two conditions. And they found that even in patients with primary bladder neck obstruction, about 14% of them had increased EMG activity as well, compared to only about 80% in those with dysfunctional voiding. So you can see here some urodynamic tracing. So in the top section, you can see primary bladder neck obstruction, very classic appearance of increased detrusor pressures during voiding, followed by very low flow rates and absence of EMG activity in the voiding phase, which is appropriate for the EMG lead. And then on the bottom, you can see, and then you can see here in this fluoro image, there's no funneling of the bladder neck, which is classic. In the bottom image, you can see another tracing for dysfunctional voiding. And again, you have increased detrusor pressure during voiding, low flow rates, but you do see a lot of increased activity in EMG activity. And this is classic. So you can see on the fluoro image, there is appropriate opening of the bladder neck here, but it's really caught up with the urinary sphincter there being really tight. This is a slightly better image for dysfunctional voiding. You can see a classic spinning top, narrow mid-urethra. So opening of the bladder neck is followed by a narrow urethra there. And again, this is in neurologically intact patients. So next up, you have Fowler Syndrome, which is a very rare cause of urinary retention. It was initially described in 1988, and certainly it seems to affect young women. They tend to have high volume retention. They may not have any sense of urgency or bladder filling. Really, there's been no obvious anatomic or neurologic cause identified in a lot of these patients, but typically there is some preceding event such as pelvic surgery or pregnancy and delivery. We hypothesize that it may be due to external sphincter contractions that are ongoing, and they essentially stimulate various different afferent bladder pathways and subsequently inhibit normal detrusor contraction. For treatment of these patients, it's a lot of conservative management with clean intermittent catheterization, bladder emptying. You can try pelvic floor physiotherapy with biofeedback. And for refractory cases, sacred neuromodulation has been shown to be 66 to 96% effective. So it is an effective treatment for these patients. So next, looking at anatomic causes of bladder outlet obstruction. So urethrostricture disease. Now, this is actually a very rare cause of obstruction in females. We do know that overall, out of all female patients presenting with voiding symptoms, about 3 to 8% of them will have bladder outlet obstruction. But of these patients, only about 4 to 13% will have true urethrostricture disease that require urethral reconstruction. So overall, when we have patients with voiding complaints, only about 0.1 to 1% of them will actually have true urethrostricture disease. This was a systematic review of various surgical techniques for treatment of stricture disease, and they looked at a set of different retrospective case series. They had about 221 patients with a mean age of 51. And one thing was there was no consistent definition of female urethrostricture disease or a consistent diagnostic criteria. They looked at treatment outcomes, and success was basically lack of need for any further intervention. They found that in patients that underwent urethral dilation, they had a mean success rate of 47% at a follow-up of 43 months. In those patients undergoing formal urethroplasty, success rates were much higher. So in the group that had vaginal or labial flap augmentation, success rates were about 91% at follow-up of 32 months. In those patients with oral mucosal augmentation, like buccal grafting, the success was about 94% at follow-up of 15 months. So again, this definition of urethrostricture, it's controversial. It's probably one of those conditions where you kind of know it when you see it. So a lot of groups define it as ability to have instrumentation. So the stricture disease, they define as a fixed anatomical narrowing of the urethra, such that the lumen does not really accommodate instrumentation without disrupting the urethral mucosal lining. Other definitions is essentially failure of catheterization or calibration of the urethra, perhaps the appearance on visual inspection, endoscopy, or radiography. Some studies looked at the ability to insert a catheter of a 14 French catheter being the definition of stricture disease. One thing that is important when you're considering urethrostricture disease is certainly distinguishing between the actual stricture itself, which is an anatomic narrowing, versus a functional or physiologic obstruction from DSD in patients with neurogenic bladder or dysfunctional voiding. So in terms of etiology of stricture disease, the majority of them are going to be idiopathic at 49%, as well as iatrogenic at 38%. In terms of iatrogenic patients, these are patients with repeated catheter trauma, possibly repeated urethral dilations. If they've had previous urethral surgery for diverticulectomy, patients that have had previous stress incontinence surgery, they're going to be much higher risk of stricture disease. Pelvic radiation certainly also increases this risk as well. Trauma can be another cause in patients with pelvic fractures or obstetrical trauma, followed by lastly inflammatory diseases, including recurrent urethritis, lichen sclerosis, and malignancy. In terms of diagnosis, again, it's looking at H&P, doing a proper uroflowmetry and getting a PVR assessment. Endoscopy is very important for looking at the appearance of the urethra. And then voiding cyst urethrogram can be helpful if you don't have access to video urodynamics. And then, of course, looking at urodynamic pressures and looking at evidence of bladder outlet obstruction on urodynamics. If you can only get access to urodynamics and you are really thinking this patient has a stricture, you may want to consider getting a voiding cyst urethrogram as well. And again, for females, the VCUG is a little bit different from males. You just really need an AP view to diagnose stricture disease in females. And then lastly, some studies have reported using MRI as well, but overall, it seems to be of low diagnostic value. It can be helpful if you're looking for other urethral pathology like diverticular disease. In terms of goals of treatment for these patients with strictures, we really want to be restoring function. Patients, of course, want to be voiding normally without obstruction. They want to maintain continence. We want to have their sexual function maintained. And of course, we want to avoid any vaginal voiding, which is quite bothersome for a lot of patients. The reported treatment options include urethral dilation, internal urethrotomy, which is rarely done, as well as urethroplasty. So looking at urethral dilation, typically the urethra gets dilated to 30 to 41 French, and patients may undergo a daily self-dilation regimen as well. Rahman's group in 2012 looked at 93 women. They had urethral dilation to 41 French. And one thing they did do was if they found bleeding at time of dilation, they also performed a plication of the external meatus to the vaginal wall. They found their overall success rates to be about 49% at 46-month follow-up. It was a very safe and effective procedure for some patients. None of the patients had any de novo stress incontinence, and there was no other major complications. For patients that had failures, they did go on to have subsequent procedures done, including further dilation at 56%, formal urethroplasty about 5%, intermittent catheterization at 17%, and then a very small subset did have urethrotomy or even attempted periurethral Botox injection. So we can see here that overall urethral dilation, the success rates aren't great. It's about 47% at a follow-up of 43 months. If they have had no prior dilation, the success rates were slightly higher at 58%. And of course, if they've had prior dilation, repeat dilation only had a success rate of about 27%. So this is kind of similar to male patients. So if they've had a single dilation that fails, subsequent dilations are really unlikely to be successful for curative intent. In terms of urethroplasty, there's different options. Vaginal or labial flaps can be used, vaginal labial grafts. You can have oral mucosal grafts, including buccal graft. Excision and primary anastomosis, whereas this is kind of the mainstay treatment for men, this is very rarely done in females. There's a very high risk of stress incontinence, and typically it can be done in patients with very short strictures or in patients with pelvic fracture disruption injuries. Looking at the systematic review, so urethroplasty did have a very high success rate regardless of which technique they used. So you can see for vaginal labial flaps, 91%, vaginal labial grafts at 80%, and oral mucosal grafts at 94%. And comparing all of that to urethral dilation, which had a 47% success. So general principles, really, if you do have patients with stricture disease, if they do have dilation or urethrotomy, you do want to wait at least 3 months after their last dilation until you have a stable or more mature stricture. You may want to consider preoperative estrogen in these patients to treat any vaginal mucosal atrophy. Again, because this is such a rare condition, there has not been any large comparative trials comparing one technique versus another. And really the choice of urethroplasty technique is primarily dictated by surgeon experience and preference. So one technique you can do, which is quite simple, is a Heineke-Mikulicz type meatoplasty. So essentially, you just make a ventral longitudinal incision over the stenotic meatus until you get to a healthy urethral mucosa. And in general, you do want to be able to pass a 20 French catheter. You then sew the borders of the urethral mucosa in a transverse fashion with interrupted sutures. There's a very high success rate of 96% reported, and it is useful for very short meatal strictures, typically less than 0.5 of a centimeter. Again, it's not really suitable for patients with lichen sclerosis, and of course, in patients with very long strictures, you'd have a long segment of urethra that you'd have to do this to, and that can lead to a hypospatic meatus. And again, that would increase the risk of patients having vaginal voiding. So you really don't want to use this technique in patients with very long strictures. There's been different flap techniques reported. So this is an example of an anterior vaginal wall flap. All of these techniques, it really just depends on where you're getting your flap from and where you're making your stricturotomy. So for the anterior vaginal wall flap, this is, you just make an inverted U incision kind of below the ventral urethral meatus. You make a ventral stricturotomy, and then you're just rolling the flap so that the tip of the flap goes to the proximal part of the open urethra, and you mature the edges of the urethra with the rest of the flap. There is a vestibular flap, and again, this is another technique. And now we're using an inverted Y incision on the dorsal side of the urethral meatus. And so you make a dorsal stricturotomy as well, and you harvest your flap kind of from the lateral aspect. So it's either on the left or right, and you get a vestibular flap that way. And you sew the tip of the flap to the proximal end of the opened urethra. There's a lateral vaginal flap, or the Orandi technique, which is very similar to in men. You're using a longitudinal type flap. And so really for this flap, you're making a ventral stricturotomy, and then you sew the edges of the flap so that the ipsilateral side of the urethra gets sewn to the flap, and then you roll the flap over and cover over the defect of the urethra and sew the remaining edge there. So in general, when you are using genital mucosa, if you have patients with lichen sclerosis or severe vaginal atrophy, you probably want to avoid using these vaginal flaps. Oral mucosa tends to be much better and more resistant to lichen sclerosis. If you have a very narrow vaginal introitus, you probably want to avoid vaginal mucosa graft. And again, you want to be aware of this complication of vaginal voiding because it is quite bothersome for patients. If you have longer strictures or more proximal strictures, these are patients that are better treated with graft procedures or lateral flap vaginoplasty. In terms of the differences between ventral and dorsal techniques, ventral procedures technically seem to be easier to perform, easier access to the urethra. However, there is more lack of backing tissue, so lack of muscular tissue, and you may also have some overlapping suture lines. So these patients may be at slightly higher risk of urethrovaginal fistula formation. In terms of dorsal procedures, technically is much more challenging. There may be slightly higher risk of injury to clitoral bodies and bleeding risk. However, there's a lot of good tissue backing, so there's less risk of fistula formation and graft sacculation. Dorsal procedures may be the procedure of choice if you think these patients may in future need an anti-incontinence procedure like a suburethral sling, or if the ventral vaginal wall appears unhealthy. And again, you can do buccal graft urethroplasty. So this is a video that I did with Doreen Chung when I was in fellowship. And we presented this at the AUA in 2017. Let me just bring up the video here.
Female urethroplasty with buccal mucosal graft for stricture disease. Urethral strictures are rare, occurring in less than.
Let me just forward to the most appropriate area here.
Is an otherwise healthy 48-year-old outcomes. This patient is an otherwise healthy 48-year-old female who presented with recurrent UTIs, decreased stream, straining, and incomplete emptying. The problem began after a vaginal delivery 20 years ago. She was found to have extensive urethral stricture disease and previously had undergone multiple urethral dilations, which failed and left the patient very frustrated. Preoperative urodynamics showed bladder outlet obstruction and incomplete emptying. Cystoscopy with a 0-degree lens showed a urethral stricture of her entire proximal urethra from the external sphincter. It's seen here as a circumferential white fibrotic scar tissue, and the bladder showed moderate to severe trabeculation. Under cystoscopic guidance, we start the procedure with the placement of a suprapubic tube, which is left postoperatively. Buccal mucosal grafts can be placed by dorsal or ventral approaches. The ventral approach avoids mobilization of the urethra, decreasing bleeding and avoiding potential damage to the clitoris. Advantages of the dorsal approach are strong mechanical support and abundant vascularization of the graft from the cavernosal tissue. Dorsal grafts are also thought to provide a more anatomic repair, and if a patient should require sling surgery in the future, which is not uncommon with extensive stricture disease, The dorsal approach avoids disruption of this repair. For these reasons, we chose a dorsal approach to the graft. A 16 French Foley catheter is placed, and a Lone Star retractor is used to gain adequate exposure. Hydrodissection with normal saline or dilute vasopressin is utilized to identify the plane of dissection. We then make a circumferential incision from the 9 o'clock to the 3 o'clock position in the dorsal aspect and dissect the urethra away from the adjacent tissues. Care is taken to avoid the clitoral tissue and nerves. It is important to identify the full extent of the stricture to ensure adequate dissection. Dissection is carried down to the bladder neck, which is identified by palpating the Foley catheter balloon. A blunt bougie probe is placed into the urethra to identify the extent of the stricture. With the probe in place at the stricture, the urethra is incised. 5-0 PDS stay sutures are placed at the apex, superiorly and inferiorly, to facilitate placement of the graft. The remainder of the stricture is then incised. Once all of the stay sutures are in place, the graft is then brought into the field. The buccal graft was defatted and placed in normal saline prior to introduction to the surgical field. The stay sutures are threaded to the graft and used to guide the graft into place. It is important to keep the field moist when working with the graft and to tie down the sutures very gently so as to not tear the tissue. Once it is in position, circumferential interrupted sutures are added. Proper patient selection is essential for female urethroplasty. The ideal patient is one who has failed conservative management and is symptomatic from her bladder outlet obstruction. While this procedure remains relatively uncommon, high durable success rates make it appealing in certain candidates. After the proximal graft is secure, the catheter or probe is replaced to ensure adequate diameter of the urethroplasty. At the apex, the graft is trimmed to the appropriate size of the defect. The apical stay sutures are then threaded through the graft and tied down. Finally, a series of absorbable sutures are placed between the bed and the graft itself to allow for enhanced revascularization during the healing process. At the conclusion of the procedure, the Lone Star retractor is removed and the incision is closed with interrupted 4-0 vicryl sutures. Post-operatively, vaginal packing is left in place and removed in the recovery room. The urethral and suprapubic catheters are both left open to gravity. The patient's catheters were removed 2 weeks post-operatively, and a cysto-urethroskopy with a 17 French flexible cystoscope showed that the buccal mucosal graft was healing well and the scope passed easily into the bladder. 1 month post-operatively, the patient was recovering well. Her symptoms are improved and she is now voiding without strain. Her peak flow rate rose to 25 mL per second with a bell-shaped smooth curve, and her post-void residual decreased to 25. On cystoscopy, the graft appeared well healed without stricture recurrence. In summary, urethroplasty with dorsal buccal grafting can be an effective treatment for female urethral strictures.
Okay, perfect. So, yeah, that was a nice little video on dorsal graft placement for female stricture disease. So really, urethroplasty in general has very good cure rates, and it is important to confirm the presence, location, and length of the stricture before you do urethroplasty. And really, again, the technique choice depends on the length of the stricture, the location, and the quality of the local tissues, as well as surgeon experience and preference. So next up, I just wanted to move over to looking at post-anti-incontinence surgery as a cause of female bladder outlet obstruction. So the incidence of bladder outlet obstruction after anti-incontinence surgery kind of ranges from 2.5 to 24%. The true incidence, however, may be underreported because patients may be more satisfied now that their incontinence is treated, and they have less reporting of de novo voiding symptoms. And then also from a lot of data from the US, a lot of patients that do need sling revision may seek out a different surgeon. So there's less longitudinal follow-up, and you may not have such high reporting of bladder outlet obstruction. The incidence also kind of varies depending on what type of incontinence procedure they had. So mid-urethral slings tend to have a lower rate of obstruction at 4% compared to other procedures like pubovaginal slings or Birch-Kulpel suspensions, for example. And we do know that obstruction can be either due to a static or dynamic change in the urethral resistance. Different causes reported, including physical obstruction of the distal urethra from maybe the sling being placed too distally, or you may have increased proximal urethral obstruction. And this is due to hypersuspension configurations. When you put a sling or a very tight suture and you're trying to recreate the natural hammock configuration, and you get hypersuspension. The Thomas trial looked at, this was a multi-center randomized trial comparing outcomes of TVT versus TOT. And what they found was that between the two groups, TVT, the retropubic group, had about an 80% success versus a transobturator group. This was at 12 months. What is important to note that is that in this trial, 9 of their patients developed some form of voiding dysfunction, and that necessitated catheterization or further revision surgery. However, the overall incidence of iatrogenic obstruction was low between both groups at 3% in the TVT group and 0% in the TOT group. These preliminary results kind of suggest that retropubic slings may be more obstructive compared to transobturator slings. There was no real significant differences between the two groups in terms of postoperative urgency, incontinence, satisfaction with the procedure, or quality of life. There was another population-based cohort of patients undergoing sling insertion between 2001 and 2010. There was 188,000 patients that underwent mid-urethral sling insertion, and they were followed for about 9 years. They did look at the causes and the rates of sling revision or removal, and they found that only about 1.3% of patients required any form of revision or removal of the sling for urinary retention. So while obstruction does occur, the incidence requiring surgical revision remains low. In terms of diagnosis, certainly these patients can present with a wide range of symptoms, and they can be more vague and subtle. And so it does require a high index of suspicion. Some of the more important factors would be the temporal relationship of their voiding symptoms with regards to the sling surgery. Looking at their specific symptoms, they may have complaints of straining to void, more Valsalva voiding, obstructive type symptoms, urinary retention, and suprapubic fullness. Some patients may also present with de novo overactive bladder type symptoms while being obstructed. In terms of evaluation, so on physical exam, you may find that the urethra appears fixed and more pulled towards the pubic bone. They may also have some obstructive prolapse present as well. On cystoscopy, these patients may have increased urethral angulation or kinking. You may see some scar tissue or even mesh erosion as well. In terms of appearance on video, voiding cystourethrogram, you may see some evidence of obstruction there. So this is a fluoroscopic image, and you can see that the proximal urethra has been kinked off, and the angulation appears quite sharp. This is classic appearance for a sling that may be inserted too tightly. In terms of management and treatment, so conservative things, essentially clean intermittent catheterization, that might be a good option if there's transient obstruction or in patients that don't really want another procedure. Some patients are so happy that they're dry that they may not want to risk releasing the sling or modifying the sling, which may increase their risk of recurrent incontinence. Pharmacologic, really, alpha blockers can be used only for very minimal or very mild obstruction. They certainly have no effect on the sling tension, but some of the literature suggests it may decrease the bladder neck resistance enough to overcome the obstruction. Certainly not something that I use in my practice. If I do think patients are obstructed, then it's really conservative or surgical treatment. And then in terms of surgery, these patients can have urethral dilation, downward traction. You can do sling loosening if it's really early on, sling incision or excision, and formal urethrolysis. So the optimal timeline for intervention is really not well defined and still something that under debate. It really kind of depends on what type of anti-incontinence surgery they had. So for pubovaginal slings, the surgery itself is intrinsically going to be more obstructive. So they do have a higher rate of initial obstruction and urinary retention post-operatively. However, there can be more breakdown of the sling because it is a non-synthetic material. So it does tend to loosen naturally over time. So for these patients, typically we do give them a longer period of time before considering loosening the sling or releasing the sling. Typically, we'll wait at least 2 to 3 months before we contemplate doing any surgical intervention. For mid-urethral slings, intervention can be done much earlier, and really that's because these are permanent meshes and they don't really have much loosening or remodeling, and so they typically don't loosen naturally. This was a retrospective cohort analysis of 112 females that underwent sling incision for either de novo voiding symptoms or obstruction over a 10-year period. And they compared early sling incision versus late sling incision, which is less than a year versus greater than a year. Overall, all of a majority of patients, 84% of them, had improvement in voiding symptoms after midline sling incision. However, they found that in patients that had earlier sling release, less than 1 year, they did have much better improvement in their voiding symptoms compared to those that had late sling incision. So really, earlier sling release may be more beneficial in improving voiding symptoms for these patients who are obstructed. So again, if you are quite early after your surgery, greater than, you may consider just loosening. So you open up the vaginal incision and you put some downward traction on the sling. And up to 96% of patients that had this done did see some improvement without any significant compromise in their incontinence ability. Sling incision or partial or complete excision have also been reported. You do have to let patients know that with this technique, there is a risk of recurrent stress incontinence of 14 to 19% reported. There's different methods reported, but they're essentially all very similar, looking at lateral incisions, midline incisions, or bilateral incisions. Urethrolysis, this is much more dissection and urethral mobility gets generated compared to just incising or excising the sling alone. So sometimes when you put a pubovaginal sling, for example, there's a lot more scarring and tissue reaction around the urethra. And so urethrolysis is important to help loosen the urethra and have your reformation of that urethral mobility that's important. Martius flap, if you're doing a urethrolysis, a Martius flap can be important to help decrease any risk of fibrosis and also gives the urethra some added support. Overall success rates of 65 to 93% have been reported. And again, there is also risk of recurrent incontinence, so you do have to discuss that with your patients. If some patients, even though they do have revision surgery, may have persistent urinary retention or persistent voiding symptoms, that can be a challenging problem. Certainly afterwards, if they do have consistent urinary retention, you do need to do more investigations. So video urodynamics is a good tool for looking at persistent obstruction and looking at causes of it. You want to make sure that, of course, they don't have a hypocontractile detrusor as cause for retention. And so if persistent obstruction is identified, actually repeat urethrolysis can be very successful with a high success rate of 91%. So I just wanted to touch base on the Martius flap here, because for a lot of these vaginal procedures, you do want to know how to harvest a Martius flap. And it is one of the simplest and most versatile interposition tissues that we have for vaginal surgery. And essentially it's placed between the periurethral perivesical fascia and the anterior vaginal wall. There are some benefits to it. Of course, there's a fibrous component to it, which makes it a good, strong flap. There are 2 pedicles there, which means that there's a lot of positional flexibility when you're looking at placement of the graft or of the flap. It's in the same surgical field as a vaginal surgery that you're already doing, so you don't need to re-prep elsewhere. And certainly cosmetic outcomes have been quite good. The superficial labial fat is undisturbed, and after a couple of weeks, you can't really even see the incision anymore. So in terms of uses for the Martius flap, it does help to improve healing, reduce fistula or recurrence in patients that are undergoing diverticulectomy, or if they've had a urethral mesh excision, because a lot of times after you excise the mesh, the urethra appears quite atrophic. And of course, if you're doing a vaginal repair for urethrovaginal fistulas or vesicovaginal fistulas, you have extra tissue that you can use to buttress over the repair site. The Martius flap can also help reduce scarring of the urethra after urethrolysis or stricture repair. And of course, it can also protect the urethra from any type of stress incontinence surgery complications. There have been some novel uses for the Martius flap reported in the literature. So in patients with vaginal mesh erosion, you can use it as a salvage procedure to cover over the vaginal mesh with the Martius flap. It's also been used for neovagina formations, and it can be used for transvaginal repair of patients that have a neobladder to the vagina fistula after radical cystectomy. It can also be useful for pediatric vaginal reconstruction as well. In terms of technique, so really it's quite straightforward and simple. You make a longitudinal incision over the labia majora, you expose a nice yellow fat, and then you use some blunt and sharp dissection medially and laterally. Certainly, you do want to be mindful of the blood supply, as we mentioned earlier. So superiorly, the blood supply comes from the external pudendal artery. Inferiorly, it comes from the internal pudendal artery. So really, you just want to divide one of the 2 pedicles, and then you can use a flap. You want to use some blunt dissection and create that tunnel between the vaginal and flap, and I always use a 3/0 vicryl stay suture on the free edge of the Martius flap, which means that when you pass the flap over, you don't have to have a Satinsky directly on the flap itself, and so you just pass it over and use it for your vaginal reconstruction. This photo here was, I think, a case I did with one of the residents. We were fixing a urethrovaginal fistula, so we harvested a bit of Martius flap for it. So in conclusion, for female bladder outlet obstruction, it is much more common than appreciated. And so you do have to have low index of suspicion for patients that are presenting with voiding complaints. Thorough diagnostic evaluation is important for these patients. Voiding cyst or urethrogram can be helpful, okay, even though we commonly think of it as something we do for male patients for stricture disease. It can be helpful in diagnosis, especially if we don't have access to video urodynamics. Urethrostricture disease does seem to exist in women, even though the rates are quite low, and urethroplasty is the most definitive treatment with the longest success rates and cure rates. And then, of course, in patients with bladder outlet obstruction after anti-incontinence surgery, you do have to have high index of suspicion and low threshold to evaluate further for these patients. And with that, I just want to thank everybody for joining us for this rounds today. Any questions or comments?